Ladies and gentlemen, you're welcome to our webinar titled COVID-19 Pandemic, Diaspora Ethnic Minorities Perspective. My name is Dr. Peter Julu, your moderator for this webinar today. I'm a specialist autonomic neurophysiologist and a consultant physician with an honorary consultant post with the Bath National Health Trust. And I'm also a senior research fellow with the Queen Mary University, London, and a fellow of the Royal College of Physicians in London. The organizer today and the host of this webinar is the Diaspora Health Strengthening Partnership, DHSP. It's a charitable organization limited by guarantee and is registered in England and Wales. It was formed in 2017 in response to a call from the Health Education England and Global Health Engagement at Health Education England, who they really needed an assistance in strengthening health system in northern Uganda. So DSSP is run by a steering committee and it draws its membership from Ugandans in the United Kingdom and abroad. These are members who have healthcare, administrative, and governance skills. The partnership therefore brings together experience from education, public health, international development, and works with health-based institutions in Uganda and also in the United Kingdom in order to develop and deliver intervention that can strengthen healthcare system, primarily in northern Uganda, but this is scalable. It can be scaled up to the whole of the African regions. Now, the panelists today, we have got one panelist, Dr. Kilama-Oceng. Can you wave your hand? Dr. Kilama is a retired, general practitioner. Dr. Kilama obtained his medical degree from Makerere University in Kampala, Uganda in 1976. He then obtained his membership of the Royal College of Obstetrics and Gynecology in London in 1983, but he went to practice in Saudi Arabia. However, he came back to United Kingdom in 1988, and after a brief practice of obstetrics and gynecology, he decided to go back to basic and became a general practitioner in 1996. Dr. Kilama trained under the Joint Committee on Postgraduate Training for General Practice within the Royal College of General Practice. He retired in 2019, just before COVID-19, conveniently. Ladies and gentlemen, Dr. Kilama, our panelists.
Thank you.
Yes, thank you very much, Dr. Julu, and the presenters for today.
Now,
okay.
Our first presenter today is Dr. Churchill Onen. Dr. Onen is our son, actually, in the diaspora, right in Botswana. He's a senior consultant physician in private practice, affiliated to Life Gaborone Private Hospital. He is a graduate at Makerere University with a postgraduate and initial degree from Makerere University. He is also a fellow of the Royal College of Physicians in London. He was awarded for his distinguished service in medicine. Dr. Onen's experience includes rural health, hospital administration, executive healthcare, civil service, academic and private practice, with a special focus for diabetes and cardiovascular diseases for over 40 years. His experience actually spread over 40 years. He also served as a member of the World Health Federation in the section of epidemiology and prevention. Dr. Onen is a founder and a patron of Diabetes Association of Botswana and was a project manager of the Botswana's pioneering retroviral therapy program. So Dr. Onen is not actually a stranger to new viral illnesses. And by the way, this is the one of the first and most successful antiretroviral rollout program in sub-Saharan Africa. Dr. Onen also had the honor to be the first Black African to give the Lilly Lecture of the Royal College of Physicians, London. He published widely in peer-reviewed medical journals, and he has contributed also to book chapters. Ladies and gentlemen, Dr. Churchill Onen, our first speaker. Dr. Dan, you can come in now. I've stopped sharing.
Thank you. Thank you so much, Dr. Peter Julu, for those kind words of introduction. I believe everyone can hear me.
Yes.
Thank you. Now, it's an honor to have been invited to the Diaspora Health Strengthening Partnership. And like all partnerships, it should take two or more to tangle. And we will tangle this afternoon with two diseases, namely hypertension and diabetes, and what impact they may have on the current COVID-19 pandemic. In the outline, I will talk briefly on hypertension and diabetes as major cardiovascular risk factors and common diseases. I will mention some residual cardiovascular risk associated with diabetes particularly, but also with hypertension. I'll make general conclusions and perhaps give some guiding principles before we go for the questions and answers. From the outset, let me quote Joseph Joubert, 1954-1824. Joseph said, the aim of an argument or a discussion, such as we may have this afternoon, should not be victory, but progress. And we hope to see progress in this session. Now, hypertension, as I said, is central in the cardiovascular continuum of risk factors. It's said to be the first westernized non-communicable diseases that occurs in rapidly urbanizing population, followed by diabetes. On a global scale, in 2015, there were perhaps more than 1 billion human beings with hypertension. That itself may be an underestimate, since not everybody would have had their pressures diagnosed. 75% of those are in middle and low income countries. In Africa, we estimate anywhere upwards of 20 to 30% of the population with hypertension. The regret is that many of the hypertensives are asymptomatic, meaning they don't have any complaints to refer to, and therefore most are unaware. Most do not take sufficient lifestyle changes or do not take their blood pressure lowering medications at all or regularly, or do not achieve blood pressure control, and therefore do not achieve reduction in cardiovascular risk factors. The definition of hypertension, I keep sliding into diabetes. The definition of hypertension depends on which side of the Atlantic you are on. If you look at this slide, maybe three things will strike you. First is that definition depends on the side of the Atlantic, as I said. Secondly, where the blood pressure is measured, whether it is in an office, at a doctor's practice, or at home. And thirdly, the timing of the blood pressure measurement, whether it's a daytime blood pressure or a nighttime blood pressure. Perhaps it's important to stress that, in fact, the method of measurement is also critical, a one-off reading versus ambulatory blood pressure monitoring for 24 hours. Going to the American College of Cardiology, American Heart Association criteria. This was derived in 2017 for the purpose of prevention, detection, evaluation, and management of high blood pressure in adults. It was actually published in 2018 in the Journal of American College of Cardiology. What we see here is that according to these guidelines, the blood pressures in the clinic, the home blood pressure monitoring and daytime blood pressures by ambulatory blood pressure monitoring are identical in defining hypertension. 130 or more systolic pressure greater than or 80 greater than. And that defines hypertension in the Americas. At night, their stringent cutoff is 110/65 or higher. And the 24-hour ambulatory blood pressure would be greater than 125 or 75 millimeters of mercury diastolic or higher. On this side of the Atlantic, the European Society of Cardiology and the European Society of Hypertension in 2018 introduced 140 or higher and 90 or higher as an office blood pressure that could be used for defining hypertension. Whereas the home blood pressure monitoring and the daytime ambulatory blood pressure monitoring are the same, but still somewhat higher by 5 millimeters for both systolic and diastolic readings compared to the American reading. Similarly, the nighttime ambulatory blood pressure cutoff is higher, 120 or greater and 70 or greater. And also the ambulatory blood pressure is higher by 5 millimeters. So it's almost like adding 5 to most of the figures except the clinic blood pressure. We need to be careful that there is a thing called white coat hypertension. Traditionally, many doctors wear white coats. That is not necessarily the issue now, but this is an office blood pressure that is elevated beyond 140, beyond 90, depending on which one is higher, in the doctor's office. Whereas when the individual is outside the doctor's office, the pressures are normal. There's also a thing called the masked hypertension. Masking means when the patient walks into the doctor's office, the pressures are normal. When they get out, there are probably adverse situations out there that raises their blood pressures, whether at home or at work or whatever factors. I need to talk about resistant hypertension only in the context of a treatment that has failed to normalize or control the blood pressure. And this should not be a topic for discussion at the moment. Blood pressure may be primary when the cause is unknown, and that occurs in about 95% of all hypertensives, and secondary in about 5%. Now, we need to clarify that we are talking of systemic arterial blood pressure elevation. And here, HT or hypertension will be synonymous with systolic arterial blood pressure elevation. And the higher value determines the stage of the hypertension. In this slide, normal would be less than 120 systolic, less than 80 diastolic. Elevated pressure is 120 to 129 systolic, with a diastolic less than 80. Stage 1 hypertension would be 130 to 139 diastolic of 80 to 89. And stage 2 would be when it is more than 140, more than 90, according to the European Society of Cardiology, as we have seen up in the previous slides. There's a thing called mixed hypertension, when one pressure is higher and the other one is normal. And then, of course, there's isolated systolic hypertension when the upper reading of blood pressure is greater than 130, or the diastolic remains normal, less than 80, or isolated diastolic blood pressure is also hypertension when the systolic is consistently less than 130, whereas the diastolic is consistently greater than 80. I will not dwell heavily on causes of secondary hypertension. One, because secondary hypertensions are rare, but we have to be mindful that there are certain drugs, including over-the-counter agents, pain-relieving drugs, antidepressants, and steroids, and more particularly illicit substances. There are primary kidney diseases that may cause hypertension, and there are a number of hormonal abnormalities associated with hypertension. And let me just say that sleep abnormalities characterized by blockage of the airways, obstructive sleep apnea, common in people with weight problems, will tend to also trigger hypertension, as would be kinking of blood vessels from the main pipe, the aorta, called coarctation of the aorta, or kinking of the supply of blood to the kidneys, renal artery stenosis. The genetics of hypertension are particularly interesting, but this forum may not be give us enough time to talk about it. But it is worthwhile saying that essential hypertension, not because we need it, but that's primary hypertension whose cause is unclear. It's a common disorder with multiple genes and gene-environment interaction. We need to know that. Now, Peter Doris posited in his work on hypertension genetics the common disease, common variant hypothesis, in which he proposes that there is enough evidence that the recent, and mark you, this is not really recent, 200,000 years ago, there was an African origin and replacement hypothesis that people who came from the African continent as the cradle of humanity probably had a genetic variation in which there is a DNA mutation in the non-recombining region of the Y chromosome. This is the male chromosome. But whether this theory works and holds true is debatable, because by that hypothesis, the origin of all human beings would be in Africa. There are others who have said there could be disease susceptibility that arose independently in various other dispersed communities. And therefore, it's not clear whether we can say that modern human beings emerged in Africa and completely replaced or overrun other humans, or whether it was a product of multi-regional evolution occurring among a wide range of human species distributed even in the old world. Whatever the reasoning, we probably won't have enough time for that discourse. This slide shows the behavior of blood pressure with southwest gradient, herein represented by populations of West African origin, Nigeria, and rural Cameroon, that as they moved westwards in the transatlantic trade to the West Indies and to the United States, presented here by Maywood, not only did body mass indices increase, but the prevalence of hypertension went up to nearly a third of the individuals. Now, we have to remember that hypertension is indeed a key determinant of cardiovascular risk, including thickening of the muscles of the heart, myocardial hypertrophy, damage to the heart muscle, which is an infarction, heart attacks, or heart failure, or bleeding or clotting strokes, and kidney damage. And people of African ancestry bear disproportionately high risks of serious complications of hypertension. It is not clear whether there are susceptibility genes that influence not only inheritance of hypertension, but also susceptibility to the side effects or manifestations or complications of hypertension. You'll be familiar perhaps with the Kenyan Luo migration study done many, many years ago by Neil Poulter and his team. In the 1990s, they worked in a Siaya district, which some of you will know in Western Kenya, a community of Luo with about 35 villages and a total of 29,000 inhabitants. The interesting question was, could they demonstrate the magnitude, timing, and cause of changes in blood pressure that occur in migrants who left Western Kenya and went to Nairobi? And over several weeks, they had a total of over 2,000 Kenyan Luo, and the main outcome finding is all I will summarize. That systolic and diastolic blood pressures correlated positively with causal urinary sodium and potassium ratio. I'm glad the chairman is a physiologist and he would understand this better than I could, and negatively with potassium creatinine ratio. But the bottom line and the take-home message is that reducing dietary intake of salt, sodium chloride, by 50%, that's about 5 grams, to less than 5 grams may lead to a substantial blood pressure reduction. Similarly, increasing intake of potassium, which is a plant salt found in fruits and vegetables and juices, trebling your intake of potassium may lead to a drop in hypertension. Now, this slide shows the Mendelian forms, very, very heritable genetic forms of hypertension, and we will not have time to go into this. Now, is there a common thread between diabetes type 2 and essential hypertension? Let us recite that insulin is an ancient peptide with acute actions on certain metabolites like sugar, like amino acids and fats, and also chronic actions on tissue growth and differentiation. But it is a potentially lethal hormone by virtue of its tight and rapid control of glucose. It's also unique in the sense that it has no central regulation, unlike other hormones. And it is basically antagonized by a counter system of hormones, and that include growth hormone and catecholamines, thyroid hormones, sex hormones, and so forth. Now, insulin resistance must then be seen as an evolutionary process to blunt the acute effects of hyperinsulinism, which is excessive amounts of insulin. And insulin resistance therefore results when a given concentration of insulin is associated with a subnormal glucose response. In other words, inability to put away, tuck away a certain amount of glucose for that level of insulin to the fat cells and to the muscle cells, the main target of peripheral insulin action. Insulin resistance also features in a syndrome that was proposed in the 1988 Banting lecture by Gerald Raven, in which he put insulin resistance, abnormalities of sugar, hypertension, obesity, mainly central obesity, and abnormalities of fats, among other abnormalities, as components of the metabolic syndrome. Here we see that there are also effects on the vessels and on pumps, and that in the case of pumps, there is a significant impact where, for instance, the sodium hydrogen system may result in excessive retention of sodium and therefore promoting hypertension. If we can then step back and look now at diabetes, by definition, this is a chronic, progressive, and incompletely understood metabolic disease, and characterized by the presence of high blood glucose, or sugar as we call it, but that sugar refers to glucose. There's variable resistance to some actions of insulin, and there's inadequate secretion of insulin for a given metabolic state. And we have talked about associated cardiovascular disorders, as we saw. The International Diabetes Federation characterizes the Africa region as composed of 49 sub-Saharan African countries, among them Seychelles, which is a high-income country, but it also has some of the world's poorest countries like Burundi and Malawi, and countries characterized by very rapid economic growth, but I can tell you that this is precarious in some settings. Cote d'Ivoire, Togo, Ethiopia. But it suffices to say that some of the most populous countries in Africa account for nearly half of all adults between 20 and 79 years of age with diabetes in the Africa region. That 70% or more of diabetics are unaware of their condition, with the highest prevalence being in the mid-50s, 55 to 64. And sadly, diabetes accounted for 77%, more than 3/4 of death occurring before the age of 60. And those are dire statistics. I'll just flash this to show the clustering of cardiovascular factors in diabetes in my work for the doctorate of medicine, which the chair probably skipped to mention. But I looked at macrovascular complications in adult diabetics. And what is shown in this slide is the clustering that nearly 90% of the individuals were obese, or 80% were hypertensive, and nearly 80% did not participate in adequate physical activity as defined in the research, and there were variable abnormalities in cholesterol. I will refer to this slide as perhaps the hallmark of my presentation. Aretias of Cappadocia, somewhere between 130 and 140 BC, was easily recognized as one of the most celebrated ancient Greek physicians. Cappadocia, as some of you may know, was a Roman province in Asia Minor, modern Turkey. I will read word per word because Aretias summarized everything that I'm about to say. That he described the characteristic muscle catabolism of diabetes mellitus as a melting down of flesh and limbs into urine. He recognized the common clinical features of the disease, namely the excessive thirst, the excessive drinking of water, the excessive passing of urine, which he described as incessant, as if coming from the openings of aqueducts. The nature of the disease, he said, was chronic. It took a long time to form, but the patient is short-lived if the constitution of the disease be completely established. For the melting is rapid and death speedy. Moreover, life is disgusting and painful, thirst unquenchable, excessive drinking, which however is disproportionate to the large quantity of urine. For the more urine is passed, the more one cannot stop them from either drinking or making water. Or if for a time they abstain from drinking, their mouths become parched and their bodies dry. The viscera seem as if scorched up. They are affected with nausea, sense of wanting to vomit, restlessness, and a burning thirst. And at no distance, they expire. That's the tragedy of diabetes, which I can only say is indeed a sweet life with a bitter end. Because it is diabetes that is responsible for 2 to 3-fold increase in circulatory death. It is also diabetes that is the leading cause of new cases of end-stage kidney failure. Similarly, it is diabetes that leads to blindness, and 50% of amputations or the cutting of limbs across theaters in the world from non-traumatic causes is related to diabetes. Now, it would seem ironic that glucose, our life sustenance, is also our poison. In this particular slide, Elizabeth Selvin looked at over 11,000 non-diabetic adults in a community-based population, with the question of whether the measure of glucose control that looks back for 8 to 12 weeks was associated with the risk of diabetes, or was it more strongly associated with the risk of cardiovascular disease and death from any cause? And here we can see that the ideal blood sugar by HbA1c would be between 5 and less than 5.5 to give you a parity relative risk of coronary events. And as the sugar goes higher, so does the risk, by 23% when the sugar is just less than 6, and by almost 80% when the sugar is less than 6.5. By American Diabetes Association, this is still not diabetes. But when it gets greater than 6.5, that is probably diabetes, and therefore the risk nearly doubles of a cardiovascular event. I want to flash a slide by Margaret Onen, in which she looked at the impact of social constraints on glucose control in adult diabetics in Botswana. It's an old study, but what is critical is that when one totaled the social support adverse score using the sum of what she used as a Norbeck social support questionnaire in diabetic individuals, it turns out that this was indeed a very sensitive indicator. A strong and direct correlation existed between adverse events and glycated hemoglobin. Importantly, the odds were highest for adverse score in those who were single, unemployed, uneducated, and had many dependents. But Ralph DiFronzo, one of the gurus in diabetology, says there might be a need for change in paradigm. Let us treat the patient, not the sugar. Let us reduce cardiovascular risk, not only the HbA1c. And here is a slide that applies the multifactorial risk concept done in Sweden, in which if you look at various risk factors, including age, being a male, total cholesterol greater than 5, systolic blood pressure more than 140, and smoking, compared to a reference population who are non-diabetic, younger than 55, female, total cholesterol less than 4.5, systolic pressure less than 140, and they don't smoke, the diabetic will still have a disproportionate risk based on their levels of blood sugar, as we have already seen in the previous slide. And as more factors emerge, so does the risk or increased risk of cardiovascular events. Here is another slide where we can basically say that the high risk of adverse cardiovascular events is disproportionate in diabetics, that most type 2 diabetics may ultimately die from cardiovascular cause. In the left-hand panel, Steve Hafner looked at about 1,300 non-diabetic subjects compared to about 1,000 diabetic patients in Finland. The risk of heart attacks was about 3 times compared to those who did not have diabetes. On the right-hand panel, this was a study by Jeremiah Stamler in the multiple risk factor intervention trial. Jeremiah and his colleagues looked at a huge number, nearly 350,000 men, screened for various risk factors that included cholesterol greater than 5, systolic blood pressure greater than 120, and smoking over a 12-year period. And what is clear is that the risk of death increases more steeply in the diabetic population, herein represented in blue, compared to non-diabetic. More strikingly, a diabetic with one cardiovascular risk factor mentioned above is nearly 5 times at the relative risk of death from a cardiovascular cause compared to a non-diabetic with 3 risk factors. In this slide, the same group of investigators demonstrate the impact of diabetes on cholesterol level, that a diabetic has a greater risk of death at the lowest cholesterol, total 4.7 or less, compared to somebody who is non-diabetic with a cholesterol of 7.5, 7.3 or higher. In the Interheart study, our analysis of the Africa Interheart component demonstrated hypertension, diabetes, smoking, abdominal obesity, and various abnormalities of cholesterol as accounting for nearly 90% of population attributable risks. A similar relationship was seen in other studies in other parts of the Interheart study that had 52 countries participating. If we categorize risk in diabetes, a diabetic would be considered at very high risk when they have diabetes and established cardiovascular disease. That would be either a coronary artery disease, other arterial disease, abnormalities in urine, kidney failure, or they would have target organ damage when they spill disproportionate amount of protein in the urine called microalbuminuria or macroalbuminuria. Or they would have major risk factors, herein represented by hypertension, dyslipidemia, smoking, and obesity. Or if they have type 1 diabetes, they should have had it for more than 20 years. A high risk, on the other hand, is a diabetic with a duration of disease greater than 10 years, but without target organ damage, plus any other additional risk factor. And moderate if the diabetic is type 1 younger than 35 or type 2 younger than 50 with diabetes duration less than 10 years. But I want you to know that lower is not necessarily better. In this study by Nielsen, lowering blood pressure excessively, represented here by the red line for systolic blood pressure in people with diabetes and hypertension, was associated with a higher relative risk of death or non-fatal coronary heart disease. That the ideal blood pressure for the diabetic might very well be about 130 or up, depending on the age of the individual. Now, others have basically been provoked to re-examine the question, is type 2 diabetes really a cardiovascular risk equivalent? And in this prospective cohort study of about 1.5 million adults aged 30 to 90, median follow-up for 9 years, almost 10 years, Rana and her colleagues in the Kaiser Permanente in Northern California, an integrated healthcare delivery system, tried to address that question. Of interest is that the outcome in diabetics was actually lower by 12.2 versus 22, challenging the notion. And they went on to say that type 2 diabetes and prior cardiovascular disease like coronary heart disease in non-diabetic patients are not necessarily risk equivalents for future events. Their conclusion was a recommendation that not all individuals with type 2 diabetes should be unconditionally assumed to be at risk equivalent of non-diabetic persons with prior MI. A more recent study looked at the residual risk, what remains after you have controlled everything that the diabetic may have. And for lack of time, I will brush through this because this is a recent study which was retrospective using data from the English practices. They had about 110,000 diabetics versus about 378 non-diabetics in the clinical practice research data link, together with about 330,000 diabetics from the Scottish Diabetics Registry. the fact is that even when all risk factors in diabetics are controlled, there is a residual risk of 21%. In this particular slide, Roshane and others demonstrated the long-term trends in excess risk of death and cardiovascular outcomes in both types of diabetes. Going through the type 1 diabetic, you will see that over the years from the late 90s to 2014, the duration of that study, death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease tended to go down across both non-diabetic controls as well as in type 1 diabetics and also in type 2 diabetics. The difference is that perhaps if you had to extrapolate these curves to the COVID time, the figure would be very different. Now, I want to mention that part of the issue is that in those studies, reduction in mortality might have reflected the elevated or improved standard of care, interventions, new drugs. Now, there are drugs that are currently advocated, and I've just given them as examples without necessarily an endorsement of the drug mentioned. And that a level 1 class would be evidence or general agreement that a given treatment or procedure is beneficial, useful, and effective, and is therefore indicated. And a level 2 in the next slide, as we will see, is a conflicting evidence and or a divergence of opinion about the usefulness or efficacy of a given treatment. And it may be 2A that should be considered, 2B may be considered. The new classes of drugs that have changed cardiovascular outcomes belong to a group of drugs called the sodium glucose transporter 2 inhibitors, the gliflozins. I will not go for EMPA, DAPA, canagliflozin, but this is a class 1A recommendation. And also the glucose, the glucagon-like peptide 1 receptor agonist, the glutides. These are gliflozins, these are glutides. So liraglutide, semaglutide, dulaglutide. That they are recommended in patients with type 2 diabetes and cardiovascular disease or at very high risk or high risk to reduce cardiovascular events. And in particular, empagliflozin and liraglutide are recommended in patients with type 2 diabetes with cardiovascular risk or at very high risk or high risk to reduce the risk of death. And I think it needs to be emphasized given the disproportionate mortality rate in diabetics of death. Whereas the more common drugs like the metformin is a class 2A level C, and insulin may be considered in patients presenting with acute coronary syndrome whose sugars are very high. And therefore, we commonly use drugs that do not necessarily have a substantial cardiovascular benefit, returning to the previous slide. Now, I want to just blend this talk with a proverb in actually having recognized most of us from that region, that lak liech pepek kirode. This is a picture of an elephant I took in northern Botswana. That the tusks of an elephant are never too heavy for the owner could not be uniformly true for diabetics because age is a runaway factor. Can't control that. Gender is a given, and ethnicity is a given. Socioeconomic status and particularly socioeconomic deprivation is a problem. And in certain settings, religious faith might influence care for diabetes. And even when we talk of affordability, that may not even be available. The targeted treatment we have talked about that alter cardiovascular outcome may not be provided. Monitoring may not be possible. And the so-called healthy lifestyles may not be possible. And therefore, we need just to be careful when we say it's a given. And as I said in this particular picture, be careful with what you put in your mouth. Now let's talk about COVID. And the question about COVID is really the substance of this presentation. the COVID pandemic has raised many questions about the impact of comorbidities, particularly hypertension and diabetes, being the most prevalent conditions. Do patients with hypertension and diabetes exhibit greater susceptibility to COVID or severity of disease or outcome, in this case, death? And do these factors work as independent predictors of severity, or are they synergistic? I'm citing a study by Esmail Mehrahin. This is from Iran of interest. But with his colleagues, they looked at the predictors of mortality in patients with COVID, a systematic review involving 114 studies. At the end, they were well over 300,000 patients from various parts of the world. They defined high mortality as greater than 10% in lab-confirmed COVID-19 cases. And the main predictors of high mortality was older age, hypertension, and diabetes. But it did appear like diabetes had an independent relationship. A more recent study by Naomi Holman from the UK asked the question, are there other risk factors associated with COVID-related mortality in type 1 and type 2 diabetics? A population-based study in England. They looked at weekly death registration in the first 19 weeks of 2020 when COVID had started, and compared a 3-year weekly average between 2017 and 2019. And COVID-related mortality was defined by ICD-10, an international classification of disease version 10, using this code U07.1 and U07.2, and whether that death was, whether COVID was the primary cause of death or the secondary cause of death. And here we see the hazard ratio. The confidence interval has been concealed for lack of time, but the fact is that in both type 1 and type 2 diabetics, being a male increased your risk of death from COVID if you're diabetic by nearly 60%. We don't know the reason. Being over the age of 70 by 89, let's say 90% or higher, even 4 times if you're over 80. And severe socioeconomic deprivation by about 90% in type 1, and I can only presume that the demands of self-care in type 1 diabetics far exceeds those in type 2, and about 63%. I'm probably lost. Now, being a Black, again, not a choice, risk is 70% or higher, or 60% with type 2 of death. If you compare this to the Asians, where that is about 57% or even just 8% in type 2 diabetics. Poor control of the blood glucose doubles the risk of death from COVID if your sugar is greater than 10% HbA1c. And therefore, high blood sugar matters. Kidney failure matters. If the kidney can only clean less than 45 milliliters of blood, that risk is more than double, and it's about 80% higher in type 2 diabetics, and gets worse with progressive chronic kidney disease. Regarding weight, in fact, BMI greater than 35 increased the risk in type 1 diabetics and not so much in type 2, but the relationship is U-shaped, such that if you are lean, less than 20 kilograms per meter squared, your hazard ratio of death was about more than 2.45 for type 1, 2.33 for type 2. But also if you are morbidly obese, BMI greater than 40, the risk is also doubled. And the ideal weight seems to be being overweight with a BMI of 25 to 29. Of interest is that systolic blood pressure greater than 140 appears to give some relative protection from death from COVID, and that seems rather paradoxical. The question is, are patients dying of COVID-19 or dying with COVID-19? And I'll leave this for a discussion. Because if you are using the ICD-10 with U07.2, the COVID virus is not identified. It is either probable COVID or suspected. Whereas the U07.1, the COVID virus is identified. So attribution of death to COVID may be tentative at best when this particular code is used. I want to highlight again that even weight or BMI is not universally a risk factor. Here in this study by Leiter, we see that age might influence mortality outcome, or rather admission or discharge from the emergency room. They had over 3,000 individuals, and being greater than 60 seems somewhat protection, even though obesity was a risk factor, whereas those who are younger than 60 had an elevated risk of being admitted to the intensive care unit. This particular slide may be sensitive in the sense of the use of minority ethnic groups. But what they are saying is that the minority ethnic groups are not necessarily to be seen as a homogeneous community, but the fact is that they have a greater burden of cardiometabolic disorders. They may have lower socioeconomic status, poorer diet, low physical activity, poor housing, which are overcrowded, multi-generational, and so forth. And that may be playing in the issue of the COVID outcome. But these researchers were not quite sure what else really explained what was going on. So I picked some highlights of poor COVID outcomes in minority ethnic groups. I'm appalled that 64% of COVID deaths among National Health Service staff occurred in minority ethnic groups, who make up only 20%. I need to be corrected, I may be wrong. But that Black ethnicity increased the risk of death by more than threefold compared to whites. And as I said, greater cardiometabolic burden in minority ethnic groups, especially the males, and that the role of obesity should be taken into account, as well as socioeconomic deprivation. But also importantly, attitudes might matter, because negative attitudes to self-care for chronic diseases or the COVID measures might compromise outcomes. If I may conclude, and I know I've gone beyond time, that several factors are associated with severe COVID and related death. Some are modifiable, some are non-modifiable. And that hypertension and diabetes are major cardiovascular risk factors in their own right. And they compound the outcome in diabetes, in COVID. That in conclusion too, that we are seeing a deadly overlap between COVID and chronic diseases, namely hypertension and diabetes, leading to a crisis of priorities for health systems already struggling with inadequate resources. That low community and awareness and social and ethnic inequalities may make the task of cardiovascular disease prevention and COVID control more complex. And that control and preventive measures require innovation, new resources, unprecedented levels of cooperation among multilateral agencies, national authorities, communities, the private sector, and other stakeholders, based not only on rigorous science, but also on a clear ethical vision. And that the guiding principles for global health should conform to the WHO, the new public health, and the ethics of the 21st century, in which WHO proposes enjoyment of the highest attainable standard of health as a right, a fundamental right of every human being without distinction of race, religion, political, economic, or social conditions. And the new public health seeks improvement in health best attained by behavior change, and environmental change by focusing on the broader influences of environmental factors and physical, social, and psychological elements, as well as healthy lifestyles. And the ethics of the 21st century embraces the amalgamation of individual bioethical issues, individual health, and human rights in the broader arena of public health, guided by the principles of equity. And if the chairman introduced my photographic skills in his introduction, I think I leave you to judge for yourself about my being an ardent photographer. This was a picture I took from the back of an audience in a cardiology conference in Dubai. But suffice it to say that hypertension and diabetes are more than a double whammy in COVID times. Thank you very much.
Thank you very much, Dr. Onen, Lukia, Churchill. Now, we are actually open for questions.
Dr. Julu, can I have a very brief comment before the questions start?
Very brief, so long as it's on the point, okay?
Yes. Just a few words to say it was a very, very good talk so far. But from the GP point of view, probably I've got to say one or two things. One, that when we talk about high blood pressure, systolic and diastolic, they may just go blow over people. The diastolic blood pressure is usually the lower one, while the systolic is the higher one. The systolic is actually the pressure that drives blood from the heart to the rest of the body, while the diastolic is the pressure that is measured during the time when blood is returning from the rest of the body back to the heart after it's been to the lung before it's sent to the lung to add oxygen. Now, the diagnosis, as you say, as you go from across the Atlantic, from Europe to America, it seems to have different standards. But this is probably due to what they consider the morbidity. When they look at what level do we have blood pressure causing trouble, maybe the Americans have a lower level at which they intervene, while the Europeans have a higher level from which they intervene. Okay, there was a very brief thing on the salt issue, which I thought I may say now for those who are in the audience, that while we move away from the villages to town, we go from area where those who speak Acholi, you'll be Kado Atona, which is really plant-based, as Dr. Onen mentioned. This is what you burnt the plants, distill the salt from there, and that's very rich in potassium. And that actually does lower blood pressure rather than raise it. While you come into town, you're going to start taking higher dose of sodium. And the damage is really from the sodium that is in the salt. So that's the brief comment I want to make now before people start asking questions.
That is excellent. Excellent modification.
Thank you. Thanks a lot.
Yeah.
Just to add, Mr. Chair, that diastolic blood pressure, the lower reading of pressure, is also the pressure that sends blood to the muscles of the heart. The coronary perfusion occurs during diastole. When the muscle of the heart is relaxing to take in blood into its chambers, the arteries of the coronaries draw blood from the root of the pipe that leaves the heart, the aorta.
Lovely.
So it's an important pressure for nourishment of the heart. But thank you very much for those clarities.
That's excellent. Now, Jasper, do you have a few questions from the public?
Yes.
Yeah.
We'll be doing this with Diaspora together, but I think the first one, which is from Ochan, what would be the right blood pressure, or what would be the right blood sugar level should a type 2 diabetic aim to maintain, and how would they arrive on achieving the target?
So that's it for Dr. Onen. What should be the right blood sugar level for a type 2 diabetes? And how can that right blood sugar level be achieved? That is from one of the audience. If you could roughly tackle that.
Do I tackle it now or take a few questions in case they are related?
This is one of the very few chosen questions. The rest will come.
Okay.
Yeah, the
Now,
rest will come.
I will tell you that basically the International Diabetes Federation, that's the overall body looking after diabetes health on a global perspective, together with the World Health Organization, would look at an average measure of blood sugar at less than 7% by what we call the glycated hemoglobin. Now, let me explain that when sugar is abound, it glues itself to a molecule called hemoglobin, which is the oxygen-carrying protein inside our red blood cells. And when there's too much sugar in the fluid in the blood, the plasma, then there is more that goes into the red blood cells, glues itself, and that gluing may be permanent at times. We can measure the proportion of red blood cells and their hemoglobin that have that HbA1c with too much glue. And if that level is more than 7%, that would not be desirable for the majority of diabetics. But in older diabetics, because of their frailty, because of their comorbidity, we would aim at a less stringent blood glucose control. Now, if you're looking at blood glucose measurement, because glycated hemoglobin, while it's the standard monitoring tool, applies to a retrospective look at the blood glucose for the past 8 to 12 weeks, that's 3 months of sugar. The instantaneous on-the-spot glucose, you would want a fasting glucose, that's a 10-hour fasting glucose, not to be greater than 6. Perhaps if you're older, 7. And if you have a 2-hour after meal glucose, it should not be more than 8 millimoles per liter. Again, there are different recommendations. If you use an HbA1c, some of the American guidelines will go for 6.5%. And therefore, they're a bit more stringent as we have seen differences across the Atlantic. But certain factors have to be taken into account, and individualization of target is the key. You cannot generally put everybody. It's not a one size fits all. There are certain situations, the workplace of the person, their shift duties, and so on, that may affect their ability to achieve that. In terms of how do we get there, the overarching principle is therapeutic lifestyle changes. I call it TLC, not tender loving care, but I think tender loving care also matters. But in this case, it's therapeutic lifestyle changes, dieting and exercise. Dieters may be recommended by a dietitian or a nutritionist. It's very important. As I showed you in that slide of the elephant, be careful with what you put in your mouth. And then, of course, there are a whole class of anti-diabetic drugs that we now know will do a lot to control the glucose without necessarily changing cardiovascular outcome, so that the circulatory complications of diabetes may not be altered. But let me emphasize that the tighter the glucose control, the better the reduction in risk from small blood vessel complications to the eyes, to the kidneys, and to the nerves. But very little may happen to the bigger blood pipes, to the brain, to the heart, and to the limbs. More recently, as I said, a new class of drugs have emerged that have profound benefit. And these were the ones I flashed in the slide, talking about the sodium glucose transporter 2I inhibitor, that is, and the GLP-1 receptor agonist. These classes of drugs where risk is properly profiled should be given to patients who can get them.
So you can hear that the summary is that determining blood glucose is a tricky one because monitoring it has got two ways of monitoring. There is you either monitor the after effect of it, after which is a sort of an average effect within about 3 months, or you can measure the immediate effect, which is just like the tsunami coming after you have either eaten or you wait, like when it has gone off, when you are fasted. And all this has got different implications in the management of the diabetes and also counting the risk factors. But you see the doctors are sort of bent to consider more of the longer effect, the average effect that takes at least 3 months to gather, which they call the hemoglobin A1C, which is really the glucose which has hung around and stuck into a different structure in the blood, which is the hemoglobin. And remember, the hemoglobin also lasts for only 120 days. It will be destroyed. So you are sort of limited there as well as to what it is. So by putting all this together, we have got some way of and means of regulating the diabetic state. That is.
Can I raise my hand and just make a quick comment? Thanks for that, Peter.
Yeah.
There is the concept of continuous glucose monitoring, and this may not apply to many diabetics, but CGM, in which gadgets are hooked to the body and take constant reading, maybe for up to 2 weeks or even longer, and gives you details of how your sugar plays out, is very, very important. Now, in CGM, you are looking at something we call the time in range. And the range then differs between, it's a range from 4 to 10 millimoles per liter. So for the first questioner, the person who asked that question, you may actually want to be time in range of 4 to 10, 70% of the time, but you can't know that unless you are doing very frequent self-monitoring or using continuous blood glucose monitoring. Thank you.
Thank you.
Can I ask a question?
Yeah, we are a panelist. Yes, Rogers, you can.
Yes, a quick one. Now, under conditions of hypertension or diabetes, to what extent do the functionings of the Krebs cycle actually come into action?
The metabolic, the production of
I'm at a
energy.
loss. I didn't hear the question.
He's saying that
It's not coming. It's not filtering through.
Okay, let me try and rephrase it for you. Can you hear my voice? Churchill, can you hear my voice?
Yeah, I
Yeah,
think
yes.
it's losing connection. Yeah.
It's lost.
Yeah, okay, okay, Churchill, you're back now. Can
Yes,
you
yes.
hear my voice?
I do hear your voice. I did not hear Prof's question, and I'm sorry about that.
Don't worry, let me just rephrase it for you, okay?
Yes.
He said that in all these considerations of the blood glucose and metabolism, where does Krebs cycle comes in. Now he's just isolating now the energy production bit.
I would have left that question for you, Peter.
Yes.
The issue is that Krebs cycle is a machinery.
Yes. It's a factory.
It's like a grinding machine that will grind millet, whatever, but the specific chemicals in the Krebs cycle are well known. And I don't think that they are significantly affected in diabetes, except in the influence of insulin, which, as we said, has a short-term metabolic effect, but also a long-term growth effect.
Okay,
but I don't think that there are perturbations in the Krebs cycle, so to speak.
No.
Unless, of course, in an acute state of diabetes, which is diabetic ketoacidosis.
Yeah. Okay, I can come in there. Let me just answer that question. You see, when we are talking of diabetes and insulin and the rest of it, we are talking of delivery of the metabolism into the cells. Now it's almost like a factory. So if you have got a factory with the raw materials. Now most of us knows that if you have got a cotton ginnery factory, okay, there used to be lorries, union lorries that used to collect this cotton from the farmers and from then bring them to the ginnery. Now, that is what the insulin is trying to do. Now, Rogers asked about Krebs cycle, which is actually the machinery now inside the cell, making use of the glucose that has already been delivered inside the cell. And then it's also a very late stage already, because the glucose has to be broken down to a certain specific particle before it can even go into the Krebs cycle. So it's almost like looking at the Krebs cycle as being the balers of the cotton that has already been gened. You see? So when we are talking of insulin, we are talking of the lorries delivering it in the ginneries. When we are talking of the Krebs cycle, we are talking of actually the balers who are already baling the gened cotton. So they are completely different. The Krebs cycle is not very much affected in diabetes as such, because they depend on the glucose that has already been delivered to them, because insulin only delivers the glucose in the cell. The cell then have to do something with it. Once they're delivered in diabetes, they are used.
It's processed.
The only problem is that they cannot be delivered. That's why one of the drug, class A drug that Dr. Ned showed is actually acting like a lorry now, helping insulin to deliver the glucose inside the cell. So that's the purpose of one of the drugs.
That's very well put, Peter. Thank you so much.
Thank you.
Yeah. Okay. Now let's. The audience must be having more questions. James.
James, you're on mute. Okay, we got 5 questions.
Yeah. Okay. What's the next question?
Oh, okay. One is concerning the comorbidity study. Can you elaborate on the meaning of independent versus dependent? In the case of type 2 diabetes, which was found to be independent risk factor for comorbidity. Any idea what causes it?
Yes. Dr. Nen, have you heard that?
Right. I'm not sure whether I'm able to go to my slides, but that may be too much.
You may have to go back to slide sharing, yes?
All right. Let me just
screen share. Yeah, screen share. Yes. If you go to screen share, then you can share the slide and then you can elaborate on that. Meanwhile, Jasper, you keep us.
Let me.
Go ahead, Dr. Nen.
Let me answer the question simply that in asking the question, let me get to the slide. I'm sorry, I'm going to go to the slide.
Yes. Just go to screen sharing.
Screen sharing, I've actually lost.
If you wave your cursor, then it will come.
Share. Screen share.
That's it.
The study I would refer to would be the Iranian study.
Yeah.
I think.
You can go to slideshow and then.
Yeah.
Yeah, there's a residual. Yeah.
I'm sorry about all of this. The Iranian study was this one here. What these investigators went out to say was, what were the predictors of mortality in patients with COVID? And as I said, it was a huge analysis of over 300,000 from different parts of the world. COVID was diagnosed by laboratory confirmation. Death was defined as greater than 10%. And they looked at these three factors as predictors, as main predictors. Now, they were able to say in a multivariate analysis that only diabetes demonstrated an independent relationship with high mortality in COVID patients. But they cautioned that there's a need for further studies to ascertain the relationship between other possible risk factors and comorbidities in COVID. But in their analysis, this was a multivariate analysis. Only diabetes had an independent relationship. The others had a collective relationship. You are old, you are diabetic, you are hypertensive, you have a high mortality from COVID, which is what I put here as greater than 10%. So I don't think I have a better slide that would try to answer this question. And in the other slides, here we are saying that in the English study, again, they were looking at possible modifiable risk in COVID patients, COVID-related mortality among patients with diabetes. Mark you, their question was that we don't really know. But what did they come up with? They came up with indication that these were the well-identified risk factors as represented here by hazard ratio. And I think it's important to understand that many factors play their role. Being a male, being older than 70, being socioeconomically deprived, being Black, and so forth. So they all have different impact depending on the type of diabetes, depending on other factors. And again, here we could not explain how high blood pressure with a systolic pressure greater than 140 would be seemingly protective. I don't know the explanation for this. But as I said in the conclusion, there are very many risk factors that determine the mortality in COVID. Several risk factors are associated with severe COVID and related death. I hope I've answered the question.
Yes, okay. Thank you very much, Dr. Onen. Okay, you can now stop sharing the slide. Yeah.
Yes, the next one is, could you explain what abdominal obesity refers to?
Okay. Just stop sharing.
Yes. Yes.
Now, obesity is an interesting subject, very dear to my heart. But abdominal obesity was initially a construct based on measurement or the morphology of the individual, the appearance of the individual. And the original description was being pear-shaped versus being apple-shaped. And pear was better than apple. In the human body, it's the torso, the trunk, the abdomen that has to be disproportionately bigger and full of fat compared to the rest of the body. There's, of course, generalized obesity where the whole person is just big, but it seems like abdominal or central obesity represents a form of fat which is in the viscera, that is an internal fat around the liver, around the kidneys, around the intestines, and so forth, around the heart. And it is that fat that poses a risk because chemically it produces a different hormone called leptin, whereas the fat under your skin in the peripheries produces a different hormone called adiponectin. And these two chemicals work differently. You will have the bad messenger from the abdominal obese person going to the brain and basically signaling overfeeding, whereas adiponectin tends to be more friendly to the body. And I think that's probably the way I would answer it. Now, you can be metabolically obese, but of normal weight. If your chemicals say that, in fact, those chemicals are in excess. So it's not only about BMI, it's not only about the waist circumference or the waist hip ratio. You can also be proportionately obese where your waist hip ratio is at 1 or less than par. But if your abdominal circumference is bigger than your waist circumference, you are abdominally obese. Now, I published a study some time ago about the need to change the cut points for abdominal girth, at least in the context of Botswana, because the WHO believes that many people in Africa don't have their own statistics, and therefore they don't have data, and we should use the European cutoff points so that a woman with a waist circumference of 80 centimeters or more is abdominally obese, and a man with a waist circumference of greater than 94 centimeters is obese. But we are not homogeneous. If you go to West Africa, West Africans are large. South Africans have very high obesity rate. In women, probably more than in men. East Africans generally lean and slim. So we are all different. And we can't then use one parameter as a yardstick for everybody. And it turns out that in the Botswana study, yet to be confirmed, maybe the men would do with 98 centimeters abdominal circumference before they can correlate with the body mass index of 30 or more kilograms per meter squared. And the women 85, not 80, to qualify for abdominal obesity. But each region probably must have their own investigations and may come up with their own cut points. Thank you.
Okay, James, how are we for time?
If we take, well, it is 1/2 past, so we should have gone to the next one. I mean, just on time as well. But I think we just need to, I think for all those who we haven't answered their questions, we already have them. As long as you have typed it, we shall get back the answers, and please try to visit question and answers section of dhsp.org.uk.
Yes, so you can still continue with asking questions so long as you type it in the chat. We'll answer them.
Yes.
Thank you.
Okay.
Yes, I think that's fine.
Okay.
We can then go to the next one.
Okay.